Great. Welcome everybody to this fourth in the Policy Exchange lecture series on levelling up. Sorry for the slight delay. The previous three were the first one was from Andy Haldane, giving us bird's eye view. We then had Paul Ormerod on levelling up in Rochdale, and the last one was Professor Richard Jones on levelling up research and innovation. And tonight, I'm very pleased to introduce Dr. Raghib Ali, who's going to talk about levelling up health and longevity. And Raghib is both a practicing medic, practicing consultant in Oxford, and a academic epidemiologist in Cambridge. He is likes to bridge opposites, not they're really opposites, but and actually, Raghib is one of the very few people who, to my knowledge, writes for both Conservative Home and The Guardian, and has been a quiet voice of reason in the sometimes emotional debates about health and ethnicity. And I'm sure he'll touch on some of that tonight, but we're also looking more broadly at the whole question of health, longevity, and levelling up. And just to remind you of the extraordinarily ambitious, one of the 12 missions in the Levelling Up white paper was the health one, which said this: by 2030, the gap in healthy life expectancy between local areas where it is highest and lowest will have narrowed. And by 2035, healthy life expectancy will rise by 5 years. There was very little in the white paper about how that was going to be achieved, and it may be that Dr. Ali will have some thoughts on that tonight. But I mean, the question of where we are now and how we are going to get to a better place on these issues of health and longevity will be addressed now by Dr. Ali, who is going to talk for about 40 minutes or so, 45 minutes. So we will have 20 minutes or a bit longer for questions. I think probably most of you will be listening to this online. We do have a few people here in the audience at the Policy Exchange office. But those of you online, I think you probably know by now how to ask a question. You raise your virtual hand, and we will hopefully hear your question. Anyway, over to you, Raghib, and
thank you.
See you a bit later.
Thank you, David. Thank you for inviting me. Thank you to Policy Exchange also for inviting me this evening. Thanks to those who have come to join us in person, and to all of those who are online for joining virtually. So as David mentioned, the white paper on levelling up is extremely ambitious, and I'm going to come to those targets in a moment. I've spent most of my career in what broadly would describe as health inequalities research, and trying to understand what drives inequalities and how we can reduce those inequalities, with a particular focus on ethnicity, particularly in my work in the UK, but also globally in terms of... Sound okay? But also, some of my work has been globally to look at reducing inequalities globally as well. But the focus of the talk today is, of course, very much UK focused. So this was the brief, which you may have seen on the advert for today's lecture. And it mentions that mission of decreasing the gap between the highest and lowest life expectancy by 2030, and raising overall health life expectancy by 5 years. I'm going to speak initially on what is the current situation, expanding on some of the data that we have, what's causing those differences, and some thoughts on what we can do about it, with a particular, again, focus on what we've learned from some of the differences by different ethnic groups in the UK as well. So this is the front cover of the white paper for those who have read it, all 300 and something pages. It's a very long document, but I have to say I didn't read every single page, but I focused on those areas that are most relevant to my work. It was quite an impressive review of the existing kind of literature, as well as a lot of, it's very data heavy, white paper. And for those who haven't read it, I would recommend looking at least at some sections that are of particular interest to you. So there it mentions, well, there are actually two missions related to health. And you could argue that all of them are linked to health, as I will come back to. But in terms of those where we have a metric which we can measure, it's obviously the one on healthy life expectancy. And then on well-being, which is also, if we consider health not just as the absence of sickness, but as a complete state of mental and physical well-being, then the 13th mission there as well, it says by 2030, well-being will have improved in every area of the UK with the gap between top performing and other areas closing. And that's obviously linked to longevity as well. This interesting kind of figure in the white paper shows how many kind of policies and white papers and green papers and actual bills have been gone through the statute book over 100 years. So it's not a new problem. In fact, I read a report recently that was suggesting that some of the differences which we see between the North and the South can be traced back to William the Conqueror, so over 1,000, or nearly 1,000 years ago. And I know governments have a habit of blaming previous administrations for current problems, but I haven't heard anyone blame William the Conqueror yet. But it's true that there are certain things which happened at that time, harrying of the North, which could have impacts much further down the line, although, of course, my focus is really on the last 20 years in this talk. So life expectancy, why is it in medicine, in epidemiology in particular, that we focus on life expectancy? It's a single number, which makes it easy to compare both across geographies, over time, different parts of the country, different parts of the world. And it's a really important measure for overall kind of trends in population health. And it reflects on all the key determinants of health: socioeconomic, educational, income, housing, employment, across the whole life course. And so it's probably the most used overall measure of health across the world. Healthy life expectancy, or as the ONS, Office of National Statistics, obviously describe it as health states life expectancy. You add a quality of life dimension because, of course, living on its own is not sufficient. We want to have a sufficient quality of life, particularly in older age, when disease and disability becomes more common. So the measure known as healthy life expectancy also estimates how much of your lifetime is spent in very good or good health. That's based on actually self-report, so how we as individuals perceive our general health. So there's a question which you may recall from the census, and for those of you who take part in the annual population survey, you would have seen the same question. It says, how does your health in general? Would you say it's very good, good, fair, bad, or very bad? And on the basis of those who answer very good or good, that's defined as being in a healthy state of life. Now, I'll return afterwards to how that might differ. So we know there's some differences internationally in how people answer that question. And there may be some differences in the UK between different ethnic groups as to how people answer that question. But historically, there's been a very good relationship between levels of healthy life expectancy and life expectancy. So generally, the longer life expectancy, also the longer your healthy life expectancy, and vice versa. But we have seen some evidence in the UK that that's breaking down for certain groups, which I'll come back to. So this graph, which those who are in the field would have seen before, it shows that, I mean, these improvements in life expectancy go back much further. In fact, this starts in 1980, but you could go back 100 years with a similar gradient. And continuous increases in life expectancy with improvements in public health, in sanitation, clean air, water, etc. And the gradient was fairly similar until kind of mid or late 2000s, so the noughties, and then from 2010 onwards, it started to flatten, and there's some evidence that it may have been even falling pre-COVID. It certainly has fallen during COVID. So in 2020, life expectancy did fall for both males and females for obvious reasons. But there is evidence, not just from here, from the USA and from other Western countries, that life expectancy has certainly started to plateau and even fall. And there's, I mean, the USA, it's often driven by mental health issues, suicide, drugs, death related to drugs. In the UK, actually, it's not so clear, although all those things have an impact. There are different theories as to why, and different theses as to why life expectancy has stalled. Some blame austerity, some blame, or some attribute it to very severe flu seasons. So 14, 15, and 17, 18 were particularly bad flu seasons, and that would have an impact on life expectancy. But I don't think there's a consensus from the reports that I've read as to why that plateau has occurred. Now, the white paper, and there's been a lot of coverage of this recently, although it may not have been as well known before, just how big these gaps are, and these geographical variation. So LA, sorry, is local authority. You've got a roughly 10-year gap between different local authorities and a 20-year gap in healthy life expectancy. So between Blackpool and Westminster, Westminster has the highest life expectancy, Rutland has the highest healthy life expectancy, and Blackpool has the lowest of both. And you can see those huge gaps. If you break it down even further by census ward, there's actually a 20-year gap in life expectancy and a 30-year gap in health. So even wider gaps if you look at the most kind of the lowest life expectancy in Bloomfield, which is in Blackpool, and Knightsbridge, of course, was in Westminster, so not far from where we are here. Now, Blackpool, I mean, it's that figure of Bloomfield, actually. This is something I just noticed recently, that the life expectancy in Bangladesh now is, in 2011, this is 2011 data, was 69 for men. So there's a part of the UK where the life expectancy is lower than male life expectancy in Bangladesh, which is, I think, very surprising given how big the gap is in wealth between those two countries. Bangladesh doesn't have a universal healthcare system either. So this figure is focusing again on Blackpool, and I know the government or the Conservative Party have their conference, I think, this week in Blackpool, and it's probably a good choice because it really is a place that, although it's been having poor outcomes in terms of life expectancy, health expectancy for a long time, that gap really has widened. You can see there, if you start from 91 to 93, the gap was there for both males and females compared to the national average or even the Northwest average. But over the last 30 years, it's widened significantly. And male life expectancy has hardly increased at all, and female life expectancy is a similar pattern. So Blackpool is a place where, unfortunately, we should be going to learn as to why that may have happened. And I'll come back to places we can look at to see the opposite, where life expectancy has improved more than the national average. So these maps and figures are from the white paper. Again, without going into all the details, you can see from the map the different colors are different life expectancies or healthy life expectancies. And as expected, the South and London, to an extent, has a kind of higher healthy life expectancy, and the North and Scotland, Wales, and Northern Ireland generally have lower healthy life expectancy. This is for males. I'm not going to go through all the figures there, but you can just see that there's wide variation within each region. In fact, Scotland has the widest variation between local authorities in Scotland, and Wales also has wide variation, and the east of England has the least amount of variation. This is for females, similar pattern. In most of the talk, I'm not going to do everything by male and female because it will take twice as long. I'm going to focus mainly on the male life expectancy differences because they tend to be bigger, the differences for males. This is data from the Office for National Statistics, and you can see that I've highlighted two places now. So Blackpool and Tower Hamlets. So life expectancy at birth, you can see that Tower Hamlets, and I'm going to come back to Tower Hamlets, but it's one of the areas of the UK, and obviously London, which has had the largest increases in life expectancy over the last 30 years, whereas Blackpool, as we've heard, is the opposite. And you can see the kind of trend over time. So obviously, Tower Hamlets is going up. Blackpool, if anything, is going down. It was quite hard to find a map, actually, from before 2001 from the official sources. I got this from the BBC website. But it does show that these problems, as I said, are somewhat long-standing. So 1992, similar pattern. So lighter is better, darker is worse in terms of life expectancy. But what this also illustrated is that life expectancy improved between 1992 and 2006, as you saw earlier, but in graphical form. And those improvements were across most of the country. As I said, there are some exceptions, like Blackpool to an extent, but generally over the course or over the whole of the UK, there were improvements in life expectancy over that time until at least 2010. This is breaking it down slightly differently, so by administrative region. This does actually show males and females. And I want to focus on the red kind of line which is London. So you can see that from 2001, where it was roughly in the middle of the regions, by 2018, it had the highest life expectancy. Similar for females. In fact, the rise for females was even greater. So something has happened in London, which I will return to. Some of it is obvious, but some of it may not be quite so obvious. So that's on geography. On deprivation, I mean, the mission mentions geography, but the gaps by deprivation are linked to geography. The gaps are not as wide, so you have roughly 10-year gaps for life expectancy and 20-year gaps for healthy life expectancy, or slightly less than that now. But you can see the gradient there in terms of what we call deprivation decile. So if you break the country up into 10 groups, most deprived to least deprived. So for both life expectancy in blue and healthy life expectancy in red, you can see that gradient. This is another way of looking at it. The axis is different on the y-axis, and that's why it looks steeper. But it's just to illustrate the point that you have these very steep gradients actually for both, and it's steeper for healthy life expectancy. There's roughly a 20-year gap in most deprived to least deprived. So the good thing in the UK compared to many countries is that, and there's many good things, but in this relation to this, the data that we have is really unparalleled. There's very few countries in the world that have the amount of data that we have, and we've seen this in COVID as well, actually. And so you can go to this dashboard, for example, the Health Inequality dashboard, and there are others as well, but this is one which is easy to use and find information not just about life expectancy, but also wider determinants of health, risk factors, etc. I'm just going to go through some of it with you today. So again, this shows life expectancy by deprivation. You can see that generally up until 2018, it was increasing, although as I mentioned earlier, the plateau. So this one we're familiar with now, but you'll see similar patterns if you look at, say, life expectancy, health or life expectancy, but also for some other measures. So the infant mortality rate, here it's obviously the opposite. So the highest infant mortality rates, again, are in the most deprived, and the lowest are in the least deprived. So the same pattern and the same gradient. Suicide rate, again, the same. So highest in the most deprived, lowest in the least deprived. Under 75 mortality rate from all cardiovascular disease. So cardiovascular disease it used to be the leading cause of death in the UK. It's now the second leading cause after cancers. But you can see exactly the same pattern. And for cancers as well. So if you take whether in infancy, so most suicides are in kind of early or middle adulthood, and then obviously most deaths from cancer and heart disease are in older ages. But on all four of those, throughout the life course, you see the same pattern of deprivation producing worse outcomes. And this has been going on for a long time, as I said, even with all the advancements through the welfare state since 1945, with pensions, the NHS, etc. The same basic pattern is there. Although there is some evidence, at least from some data, that these gaps were reducing, and between sort of 1990 and 2010. But again, they've started to widen a bit more since then. So this next part, which really focuses more on my work as a clinical epidemiologist, so I'm not for those of you who've been following me during the kind of COVID era, they will know that I'm not a mathematical epidemiologist, I don't produce models, but as a clinical epidemiologist, I'm interested in looking at data and trying to understand what it tells us about causation in particular, but also treatments. But this is focusing more on causation. So if you look on the right-hand side of this figure, the 5 main causes of death and disability in the UK, so heart disease, cancer, chronic lung disease, diabetes, mental health disorders. And there are certain risk factors which we measure in whether in primary or secondary care that I mentioned there. I want to focus more on what we call the causes of those causes, so the risk factors like tobacco, alcohol, unhealthy diet, physical activity, and air pollution. And finally, what we call the most distal risk factors, so the causes of the causes, which are socioeconomic, genetics. Epigenetics is really how your genes are expressed depending on the environment, and then early life exposures. So this is a simplified kind of, it's obviously much more complicated than this if you take into account all risk factors, but this is a kind of outline of how we would approach this question, is to understand what's causing these differences. And it is very much driven by social determinants of health. And this has become more well established over the last kind of 3 decades, particularly with the work of Michael Marmot and others, to understand that it's the social and environmental conditions which really have the biggest impact on health outcomes, much more so than what we do as doctors or nurses or other healthcare professionals. So although healthcare is important and access is very important, particularly in countries where you don't have a universal healthcare service, and this is why we see such poor outcomes in the USA, for example, for people who don't have health insurance, and of course in poorer countries they don't have universal healthcare. They do have a role, but most of the determinants of health lie outside the healthcare system. So Michael Marmot, I mentioned, this was his, he produces lots of reports. This was his last report in 2020, talking about how life expectancy had stalled and that hadn't happened for more than 100 years. He made the point that it's not just how well the health service is funded and functions, although that's important, of course, and that's what a lot of attention is paid to. but it's more closely linked to conditions that people are born, where they grow up, where they live, schools they go to, the workplace, etc. This is one of his well-known quotes. So they're not inevitable and can be significantly reduced, and they stem from avoidable inequalities in society. Some are avoidable, others maybe less so. And the Royal College of Physicians, he says we have to recognize the link between poverty and health, and government must act to tackle the significant and growing health inequalities that exist in our society. These quotes are not recent, actually. They've gone back. So these things that affect both governments of both colors have been going on, as I said, for a long time. So this is a figure that those in the field would be familiar with, which shows, again, how these various factors or causes interact. So age, sex, and genetic factors, for example, epigenetic factors, your individual lifestyle habits, social and community networks are also important. And then there are things which really the government has more role in, so food, education, the work environment, unemployment, etc., healthcare services. And then finally, the kind of general conditions which are sometimes even above government's power. This is from the World Health Organization's report called Closing the Gap in a Generation. So again, this was produced more than nearly 14 years ago now. And again, the intention was to see how we can close this gap which exists. This is actually an international publication because these gaps exist in nearly every country. In fact, they do exist in every country in the world, including those that are doing better than the UK in terms of inequalities. But those gaps are still there. And again, making the same point that you have to focus on the social determinants. This figure, I'm not going to go through everything on this figure, but it's just the bottom part of it, which is people have tried to quantify how important different aspects are to health outcomes. So, and there's not full agreement. The World Health Organization estimates slightly less than this because it does depend from country to country. But where you have universal healthcare, it's likely only about 20% of the health outcomes in relation to health, life expectancy, health life expectancy are due to healthcare related to access of care and quality of care. I mean, for me personally, as David mentioned, I am a practicing clinician, and I spent most of the early part of my career just seeing patients as an NHS doctor. But it became quickly apparent that most of the patients who I was seeing, and it's still true, have preventable conditions. We heard last week from the Secretary of State as well, making a speech at the Royal College, that I think he said 2/3 of patients, in our hospitals have preventable conditions that are preventable. So that's one of the main reasons why I went into public health and epidemiology, because I understood that I could make a bigger difference by working in that area. Most of what we do in health research epidemiology is focused on health behaviors, so tobacco use, exercise, diet, alcohol, etc. Less so on the socioeconomic factors, which of course come under different parts of government, different parts of society, family, community, etc. But that is the biggest kind of determinant of health, are those socioeconomic factors. And until we recognize that, then it's very difficult to address those gaps. And I think there is definitely a much greater recognition, even the time that I've been working in this field, of the critical role that socioeconomic factors play. This final figure is really just showing how, over the course of your life, these various social determinants kind of interact and accumulate both positively and negatively. And one of the problems we had with prevention historically is that when we do intervene to prevent diseases, it's often at a late stage. So most of our prevention efforts, and there is an argument for doing that because with limited resources, you have to target your resources where you think they'll have the greatest impact. And so they tend to be in older ages, above the age of 40. Most like the NHS Health Check, for example, is above that age. Whereas ideally, if you really want to make a difference, you would have to start earlier. But of course, that takes more resources, and you have to target more people. But this is really one of the areas going forward where there needs to be a greater focus. So early years and even prenatal, is the earliest time you could start making sure that women have healthy pregnancies and deliver in a safe environment, etc., are able to bring children up in as good an environment as possible. Even by the age of 4, when children start school, you see these gaps in reading ability or social abilities, etc., from a very early age. And it's very difficult to close that gap afterwards. So the white paper does recognize this, although, as David said, it doesn't have a huge amount in terms of specific interventions for health. I would argue that most of the other interventions they suggest, because they are linked to socioeconomic factors, whether education or employment or other aspects of regional policy, they will have an impact on health. But it does recognize in the white paper that it's driven, I mean, it mentions the causes there, so smoking, alcohol, poor diet, and then it talks about some of the causes of the causes, demographics, quality of housing, etc. But it doesn't go into a huge amount of detail, to be fair. And it mentions access to and quality of health services. They can vary by area, although actually that's where the least amount of variation occurs. So nearly everyone in the country has access to both primary, well, everyone has access to primary and secondary care. In terms of the level of access, it's not exactly the same, but no one does not have access. And there are gaps. So, for example, the waiting list, if you're in the most deprived area, is longer than if you're in the least deprived area. But they're not the kind of gaps that we see for the social determinants. So looking again from this dashboard that I mentioned from what used to be called Public Health England, again, it shows, as you'd expect, that poverty is highest in the most deprived areas. But it focuses on children here because that's, as I said, where interventions really need to start. Education, so this is comparing free school meals and non-free school meals. So even you can see that very large gap between those who are on free school meals, so not achieving a good level of development over time. So although things have improved, the gap is still there. This is showing attainment 8, so it's a measure that we use, so when I say we, I'm a school governor as well, so I'm familiar with this, but to measure progress of children in secondary schools in particular. And you can see, again, the kind of, that the higher scores tend to be in the more prosperous areas in the south, and to an extent in London as well now, which is a change actually. So London, this is one of the changes I mentioned that's happened in London over the last 20 years, significant improvements in educational attainment. That's one thing to keep in mind. This is another measure of looking at levels of qualifications. So again, without going into every region, you can see that it varies a lot by across the country. Here, maybe it's expected that London will have a higher proportion of what we'll call level 3+ qualifications because there's a higher proportion of graduates and universities here. This is other measures, which again, these are from the white paper now. So London, as expected, has the highest human capital per head, and the northeast in England has the lowest, and Northern Ireland in the UK. And then the different qualifications, another way of measuring it, is shown there. Again, London having significant advantages in graduates and other levels of qualifications, and again, the northeast faring least well. This is the employment rate. So this actually shows how London has improved over time. So it didn't used to have the highest employment rate if you go back to 2004, but by 2020 it has got the highest employment rate. And I think Wales and the northeast have the lowest. And Wales used to have the lowest life expectancy and healthy life expectancy, but that has improved over the time compared to Blackpool at least, which now, as I said, has the lowest. It's another measure, 16 centuries, not in education, employment, or training. Again, generally, there's a slight difference here in the pattern that one of the middle kind of deprived groups in yellow actually has the highest proportion, and I don't actually know the reason for that, but I'm sure people are looking into that. But in general, the pattern is the same, that more deprived, you have a lower proportion in education, employment, or training. So what impact does that have? Going back to early childhood exposures and school, etc. Obesity, which is a key risk factor, not just for diseases that you may think of, like diabetes, but also for many cancers, also for cardiovascular disease. And it's likely to be the leading kind of risk factor now for non-communicable disease as a whole, even bigger than smoking. And you see these patterns of obesity being higher from an early age. This is just year 6, the end of primary school. So again, the most deprived children have the highest levels of obesity. And there's the same gradient there across deciles. Smoking, of course, is still very important, particularly in older age groups. But it's, again, a similar pattern. This actually doesn't use deprivation. It uses, this is from the annual population survey. It uses kind of employment categories and managerial professional having the lowest smoking rates, and routine and manual having the highest smoking rates. This is from the white paper, again highlighting the regional variations in obesity on the left and in smoking on the right. And again, without going into all the details, the patterns are similar. So all of these patterns, whether you're looking at outcomes, risk factors, causes of causes, all the patterns are similar both for geography and deprivation. So it's not difficult to kind of diagnose what the problems are here. It's been known for a long time. The key is really what do you do about it. And obviously there has been some evidence of success from some policies, particularly between 1990 and 2010. Alcohol, similar pattern. So alcohol has become a major risk factor. It's always been a risk factor for some diseases, but it's become a particularly important risk factor for many cancers, so including breast cancer and others. And the interaction of tobacco and alcohol in particular are very bad for cancer outcomes, alcohol and tobacco for cancer outcomes. Well-being, so this was mentioned in the white paper, different kind of levels of well-being, and this relates to employment status. So generally, people with a low well-being, so if you're unemployed, you have lower well-being than those who are employed, as you'd expect. These are some of the determinants of life satisfaction, which again, I'm not going to go through every single one there, but you can see that generally people who are married or in a civil partnership have better life satisfaction. You can see that generally people who are, just going down, those who live in their own houses, own their own houses, have better life satisfaction, and various other measures there. This is from the white paper as well. So I'll just spend a couple of minutes on this slide. So these are the recommendations which came from the first Marmot review, so Michael Marmot. And I would say, it's always hard to achieve consensus in anything in medicine or policy, but I don't think there's much disagreement about the objectives here and the policy objectives here. So helping children to have the best start in life, to maximize their capabilities, have control of their lives, fair employment, healthy standard of living, sustainable places and communities, and the role and impact of ill health prevention. So as I said, these, I think most would agree that these are what we're trying to achieve. And to be fair, bodies like the Institute of Health Equity, which Michael Marmot runs, and others, have produced a lot of policy papers over the years, and so have government, as to what should be done here. And I'm not actually going to talk about that because there are others who are more qualified to talk about the impact of policies on social determinants of health. But there's a lot of material out there, and it's more about implementation. And I think what has changed, at least in the time I've been looking at this, is that there's a greater kind of understanding and acceptance that we need the whole of government, across government, different departments, and not just government, but government working with civil society, with community groups, with other groups, with society as a whole, what we might call the big society in times gone by, as well as individuals, of course, to work together to make these changes. So I mentioned the various policy papers, and there are lots. I mean, when I was preparing for this talk, some of them I've read before, but there are so many. Almost every month there's another paper that comes out from these various foundations as to what we should do. I've just mentioned 4 kind of common themes there. 1, you must target the social determinants of health. 2, prevention is the key. 3, it must be cross-government. And 4, it must be across society. I'd say these are 4 points of agreement in all the policy papers. Prevention, again, last week, when Sajid Javid spoke, he mentioned the 3 Ps, and one of them was prevention, which is very welcome. But it's not exactly new, because even the healthcare plan from 2019 did have prevention as one of its key objectives. So, of course, because of COVID, lots of things have not been able to be implemented, particularly by the NHS. But the second point there is it mentions a particular focus on the communities and groups of people most affected by these problems. So it's really targeting interventions or ensuring that interventions produce outcomes in those places, or produce better outcomes in those places which are furthest behind. And that's why the concept of levelling up, of course, is very powerful, because places like, not just Blackpool, there are many places in the north, in the coastal areas, even some parts of London, if you look at the figures, which have been left behind or are being left behind. And so the concept of levelling up is extremely powerful, I would say. And we will have these metrics. I mean, the white paper mentions a couple, but there are many metrics we can look at. I've gone through some of them today. And in fact, you'll start to see the changes in the kind of social determinants first, then the risk factors, and then in life expectancy and healthy life expectancy later. So coming back to London, so why am I focusing on London? So it's mainly because it's had the biggest improvements in life expectancy over the last 20 years. More so in women, but also in men. So you've got men on the left and females on the right. But why I wanted to focus on the last part of the talk today, which I didn't find in any of these policy papers or government reports, but perhaps that's inevitable because it's very new data, and maybe they've not had time to digest it yet. But there's another feature of London, for those of you who live in London or know London well, which is different, and that it has a very high proportion of ethnic minorities. So in fact, they're not minorities. So London has a majority of non-white British, as do, I think, Luton, Leicester, and Slough. I think they're the three places. But London, I think, was the first to cross that threshold. So is there something in terms of the ethnic makeup of London which has produced some of these improvements? And that's what I'm going to talk about a little bit now. I mean, there are other potential explanations. Of course, London gets more resources than other parts of the country. It's had improvements in education across the board. But again, that could be driven by ethnic minorities as well. But I will show that there are some patterns which we find, not just in London actually, but across the country, which are somewhat counterintuitive. So I've described it here as area-based life expectancy based on ethnicity. So if you look at the 20 most ethnically diverse local authorities, which have, on average, 50% non-white British. So if you go to 2002 or even further back to 1992, they had lower than average life expectancy. So I've mentioned male life expectancy, that's what MLE stands for. So in 2002, on average, those 20 local authorities had a lower life expectancy of about 1 year. Whereas by 2018, it had become above average by 0.5 years. And what's unusual, and it's not unusual for places to change, but what's unusual is that these ethnically diverse local authorities are more deprived. So that's what's unusual, that if you're more deprived, you're meant to have a lower life expectancy, as I showed earlier. But these particular areas have got a higher life expectancy despite being more deprived. They're all in the bottom 25% in terms of deprivation. The average increase you can see there is significant. It's 6.1 years in those local authorities versus 3.5 for England and 4.9 for London. So even if you compare to London, it's higher than what's happened in London. And the final point there is that the most ethnically diverse London boroughs have had the largest increases and are now above the national average, despite also being some of the most deprived local authorities in the country. So places like Tower Hamlets, Newham, Hackney, these are extremely ethnically diverse. Historically and even now are deprived and have some points of extreme deprivation. But their life expectancy is now above the national average, which is a big change and a very, as I said, somewhat counterintuitive finding. So this table, what it shows, so I guess I hope you don't have to look at every single cell on there, although I'm happy to share the slides afterwards for those who are interested. So you can see that England, for example, in the top row, 80.5% white British, life expectancy going from 1992, 2002, 2010, 2018. So of course it's increased over time. If you look at, I've mentioned 3 regions there, so London, which now has the highest life expectancy, with very significant increases over time, and then the 2 regions with the lowest life expectancy are the northeast and the northwest. And all have improved by 2018, but the level of improvement was less in the northeast and the northwest. Now, if you look at Tower Hamlets, which is nearly 70% non-white British, male life expectancy has gone from 70.6 in 1992 to 80.3 in 2018. That's one of the largest, if not the largest, increase in the country. Newham, similar. It's even more ethnically diverse and has had a similar pattern. And Hackney, again, a similar pattern. The figures there on IMD, so IMD stands for the Index of Multiple Deprivation, which takes into account various aspects of deprivation. So there are 318 local authorities, and you can get a rank. So Tower Hamlets in 2002 was ranked the most deprived local authority in the whole country. Hackney and Newham were in the top 5. They have improved over time, as you can see, and for those who live or visit those areas, that's quite apparent in some of the development that you can see there. But they're still in the bottom 25%, out of 318. So they haven't suddenly become extremely prosperous areas. They're still in the more deprived quartile or quintile. But despite that, as I said, their life expectancy is now above the national average. Now, if you look at the bottom 3 rows, so Blackpool I've mentioned before, Hartlepool and Gateshead I've added now. So this is the northwest and 2 places in the northeast. So if you look at their life expectancy in 1992, it's actually slightly higher than Tower Hamlets, Newham and Hackney. But fast forward sort of 26 years, and you see very little improvement compared to both the national average and particularly compared to those London boroughs. So Blackpool obviously has the least improvement. Even Hartlepool and Gateshead have had relatively little. I've put Gateshead there actually because it has a level of deprivation quite similar to Tower Hamlets and Newham. So you can see its rank there is similar. But there's a significant gap there in life expectancy if you look at 2018, so about 2.5 years. So this data, I mean, when I said it's not, I mean, it's publicly available, of course. I've just taken this from Office for National Statistics data. But I don't think it's well known, and I don't think it's widely discussed. I mean, I'd written something recently in the BMJ with others on life expectancy, but we focused more on ethnicity. But this is also another way of looking at it. It's based on area. But they're obviously linked. This is, again, the ONS produces something called the Health Index. The reason I mention this is, I mean, Tower Hamlets does have better life expectancy, and as I've shown, but there are other aspects of health which are not as good. And if you go to this website, and again, I'll share the slides afterwards, you can see that it doesn't perform as well on some other measures. So it's not that Tower Hamlets is, improved in every aspect, but at least in life expectancy, it has. Blackpool, unfortunately, tends to do badly on all measures, and I'll show that in another figure later on. So now I'm going to focus a bit more on the ethnic data. So Pakistanis and Bangladeshis, as you can see at the top there, are the most deprived ethnic groups in the UK. So nearly, well, 50% or more than 50% of Pakistanis and Bangladeshis are in the 2 most deprived deciles. So they are by far the most deprived communities of any ethnic group in the UK. You can see Black African, of course, have deprivation there, as well as other blacks, etc. And you can see there's a gradient in there. Indians, much less so now. So they've made very significant advancements in deprivation measures over time, as well as Chinese. Now, these figures came out over the summer. This was the first estimates from the Office for National Statistics for life expectancy. This is based on the 2011 census, and they'll be able to update it with the 2021 data, census data, soon. But this is the best and the only estimates actually that we have of life expectancy in England. And the finding, which was surprising to many, was that almost all ethnic minorities had higher life expectancy than whites, both for males and females. The only group which was either lower or the same was the mixed group, which is white, generally white plus another ethnic minority group. You can see for men that Black African and Pakistanis had particularly high life expectancy, and for women, Bangladeshis and Black Africans. And this data, I'm not going to go through it in the interest of time, but there is quite a lot of data now, actually. So one of the kind of things that happened over the last 2 years, and with my other role as the independent expert advisor to government on COVID and ethnicity, was looking, of course, at the disproportionate impact of COVID on ethnic minorities. And there's no doubt that there has been a significantly higher death rate in pretty much every ethnic minority compared to whites, and particularly in Pakistanis and Bangladeshis because of COVID. But what that also meant was that people started looking at other outcomes, including life expectancy, as you see here, but many other outcomes. And in fact, if you look at all the data, whether from this study from the Office for National Statistics or from Public Health England did their own analysis, Open Safely, another study, did their own analysis, they all found the same thing, actually, that pre-COVID overall mortality was lower in Asians and blacks than whites, i.e. higher life expectancy. So all the data is actually quite consistent, and I'll show you why it also fits with individual disease data. So this is showing something similar, just in kind of table form. There's also data from Scotland, which has found similar for particularly Indians and Pakistanis. And I've mentioned some of the other studies, so Open Safely, Public Health England, the ONS longitudinal study. So they're all consistent. Green basically means that the ethnic minority has a better outcome than whites. Amber means a similar outcome, and red means a worse outcome. So in relation to life expectancy and overall mortality, there's no studies which are showing worse outcomes. For healthy life expectancy, it's not quite the same picture. So for healthy life expectancy, particularly in women, there is evidence that Indian, Pakistani, and Bangladeshi women have worse healthy life expectancy. But we don't have any kind of good data on that since 2011. So the census that's just been done will provide a better update as to what the current picture is. But as I mentioned at the beginning, there can be differences cross-culturally, as we see internationally, in the way that people perceive their health. And there are some conditions which are more common in South Asians, for example, diabetes and hypertension, and you may feel that has a significant impact on your quality of life and your health, whereas somebody else with another condition, like cancer, for example, is more common amongst whites. It tends to be either cured or often fatal. So the type of disease mix also has an impact on that question, as well as I said, cultural factors. So this table, it's a busy table, and we don't look at every line, but again, it's illustrating that if you look at the top 30 causes of death in England, what this shows is that all causes, as you'd expect based on the data I've just shown, that Indians, Pakistanis, Bangladeshis, Black African, and Black Caribbean have lower age-standardized mortality rates or lower mortality than whites. That's also true for all cancers. It's not true for cardiovascular disease. So Indians, Pakistanis, and Bangladeshis have worse outcomes for circulatory disease, including ischemic heart disease, cerebrovascular disease to an extent, and diabetes certainly, and hypertension is a particular problem in that Caribbean population, as well as to an extent in Black African population. So for cardiovascular or cardiometabolic diseases, ethnic minorities tend to do worse. For cancers, particularly South Asians, particularly for South Asians, they tend to do better for cancers. So most of the green diseases you see there are cancers. Most of the red are cardiometabolic disease. And the reason that's important is because cancer has become the leading cause of death, as you can see there, over time. And I'll show on one of the slides coming up how that changed over time. But currently, it's the leading cause of death, all cancers combined. The last two columns is just to illustrate what I've been talking about throughout the talk, is that deprivation obviously produces worse outcomes for pretty much every disease, and also contrasting the picture in the USA, where blacks tend to do worse than whites on pretty much every disease outcome as well, and have lower life expectancy. So the picture is different here. So the summary of the results there, I'll mention the last point there. So for the 30 leading causes of death, which are responsible for about 80% of all deaths, ethnic minorities had lower mortality rates for half, 15 and higher for 8, and no difference for 7. So these, as I said, these findings were somewhat surprising to people and one of the reasons they were surprising, most of the work that's been on ethnic minority health has been on cardiometabolic disease, where ethnic minorities tend to do it. There's been much less on cancer. My own background work had been mainly on cancer, so it wasn't as big a surprise to me. This data is for 2020 from the Office for National Statistics. So the column, which is mainly in red, is deaths due to COVID-19. As I said, every ethnic group apart from Chinese had significantly worse outcomes, particularly Bangladeshis and Pakistanis, and this has continued in 2021 as well. But you can see that deaths due to other causes, reflecting the pattern pre-pandemic, was mainly better compared to whites. And if you combine the two, you see the pattern that you do. So for Pakistanis and Bangladeshis, it tends to still be worse, and for Black Caribbean men. For women, there was no significant differences, and for some, it was better. But even in 2020, and this data is online, I didn't put the table up because it's a very long table, but it's available online for those who are interested. Even with that disproportionate impact of COVID on ethnic minorities, they did a breakdown by deprivation quintile, and it showed that even in 2020, that British whites had the highest overall mortality and the steepest deprivation gradient. And when the data is updated, kind of for years after 11 to 14, I'm sure a similar pattern will be found. So this shows, as you might expect, that deprivation and geography are the key drivers across ethnic groups. But there is a slightly different pattern in Pakistanis and Bangladeshis in particular. So it's the the bottom half of this I'd like to focus on. So the normal gradient that you see for non-COVID deaths in men, if you look at the white, there's a very obvious gradient there in the mixed group as well. In other ethnic minorities, there's not such an obvious gradient, particularly for Bangladeshis and Pakistanis, which is the group I'm going to focus on because they're the most deprived. We don't see that similar gradient. These are data that we have on risk factors. So you can see that the main risk factors for the diseases that are the major causes of death and disability, again, a mixed picture. So South Asians have worse on some risk factors, better on others, and same for blacks. But this really impacts on the relative rates of cancer. So tobacco and alcohol are less common in Pakistanis and Bangladeshis, and so they have significantly reduced risks, for example, of esophageal cancer, colorectal cancer. Breast cancer is mainly driven, it's not on this table, but breast cancer rates are one of the main risk factors or protections is having more children, and they tend to have more children. And then, again, the final column there shows that for all risk factors, the most deprived or the more deprived groups have worse kind of levels of risk factors. I showed some of these earlier, but including poor diet and low physical activity. So this paradox, what I'm describing as a paradox, it hasn't really been described this way before in the UK, although in the US, people refer to something called the Hispanic Paradox, where Hispanics, despite being more deprived, have higher life expectancy. We're finding a similar pattern now in the UK. But it does vary from group to group. So if you look at Black Africans, it's likely, and we've got some data on this, that they're relatively recent migrants. Most of them migrated here either to study or work. And so there's a strong healthy migrant effect. So obviously people that migrate have to be in a certain level of health, particularly if they're taking up a place at university or a job. That healthy migrant effect actually is not as strong in Pakistanis and Bangladeshis or Indians going back kind of pre-1970s. So most of those who migrated in the 50s and 60s and even 70s could migrate without any reason. They as kind of previous subjects of the British Empire, they had the right to move to the UK, including my father, for example. And so all of, a large proportion of the current South Asian community and the Black Caribbean community came, in that way. So that healthy migrant effect is not as strong, although there would be an element of that, and there have been studies done to try to quantify that. But for Pakistan and Bangladesh, it's not as strong an effect. The change in the relative balance of leading causes is what the graph on the right shows. So you can see that in purple, both if you measure it by deaths or years of life lost. So years of life lost is a better measure to understand the impact on life expectancy. Because obviously the younger, everyone has to die, of course, but the younger that you die from a particular cause, the bigger impact it has on life expectancy. So again, these very significant drops in cardiovascular disease or ischemic heart disease mortality due to both improvements in risk factors like less smoking and better treatments, so statins, blood pressure treatments, etc., as well as treatments that we give in hospital, have had that significant improvement. Whereas for cancer, which is the kind of top green line, you see it hasn't really changed that much over the last 30 years. So if we had data, which we don't, but if we had data looking at ethnic minority life expectancy in 1990, I'm confident it would be lower than whites. And if you look at Tower Hamlets, for example, which has the highest Bangladeshi population, it was lower, but now it's higher. And this, I think, is explained by this change in the relative balance of cancer and cardiovascular disease. The third point about the different relationship between deprivation and risk factors is also important. So as historically, deprived communities, which are obviously mainly white, had high levels of tobacco and alcohol use, unhealthy diet, living alone, etc. Does that apply in Pakistani and Bangladeshi and maybe other ethnic minority communities? Not really. So obviously there are religious reasons why people don't drink alcohol, and there are cultural reasons why particularly women don't smoke. Diet is a difficult one to measure and to look at its impact, but diet may be important. Living alone, I'm going to come back to, but there's other kind of social kind of factors which are different. Pakistan and Bangladesh, again, the deprivation point I've made, they are more deprived. They also have potentially other disadvantages, both kind of racism that they would face as being of a different ethnicity, also religious discrimination, because most of them are Muslim. So they have a kind of triple disadvantage, and that's why in some ways it's even more surprising that they have these better outcomes. So I mentioned about living alone. So this data, again, is relatively, although it's been available, it hasn't really been focused on before, but it became relevant during COVID. So you can see there that Bangladeshis and Pakistanis, for those who are above the age of 70, so this is focusing on those above the age of 70, it's very rare for someone in a Bangladeshi or Pakistani community, or family rather, to live on their own. It's certainly very rare, but generally a majority of Bangladeshis and a significant minority of Pakistanis live with their children and grandchildren. So you can see that if you take both groups combined, about half, whereas in the white community it's only 2%. So a huge difference, and even for Indians, Black African, Black Caribbean, you see it's a much smaller proportion. Now for COVID, this was a particular problem, particularly in the second wave onwards, where of course if you are an elderly person living with both people of working age and children, you're much more likely to be exposed to COVID. And this actually has been shown now to be one of the main drivers of the higher COVID death rates in Bangladeshis and Pakistanis. You can also look at household size here. They've combined Pakistanis and Bangladeshis together. So again, it's very rare for Bangladeshis and Pakistanis to live on their own or even in a kind of two-person household. So compared to whites, where that's nearly half of households are either one or two people, for Bangladeshis and Pakistanis, it's only 7%. 7.8%. So these are, again, huge differences. So there's very big differences, as I said, in the social structure. The other difference, I haven't got a table for this, but there is some evidence, again, which we picked up during COVID, to show there's higher levels of mixing between, we don't have this by ethnicity, we have it by area. So for example, London had higher levels of kind of household mixing than other parts of the country, both during the pandemic. And now that the pandemic is not over, but this study is continuing, and so we'll see how those patterns continue beyond the pandemic.
Can we wind up the next minute?
Sure. I haven't got a clock in front of me, but okay. Education. So the geographic differences in social mobility are mentioned again in the white paper, and as I said, ethnic minorities, particularly actually here, it's Indians, Chinese, Bangladeshis, and Black Africans tend to do better, and particularly those on free school meals. So those who are from ethnic minorities who are on free school meals tend to do better than whites. And again, personal experience for me, having been on free school meals, is certainly my own experience, that when I went to university, it was very rare for people on free school meals to go to university in those days. But it's become much more common now, particularly those from ethnic minorities. This is shown at the point I made about free school meal eligibility children doing better from ethnic minorities. Okay, I think I'm on only a couple of slides to go. But this was a point I was making earlier, but comparing Blackpool and Tower Hamlets, it's not that Tower Hamlets does well on everything. So living in London is associated with high levels of anxiety, for example, than living in other parts of the country. But if you took at these 12 key indicators, then Blackpool did worse on 9 and better on 3. Tower Hamlets did better on 9 and worse on 3. This is my last slide. So final points relate partly to what we can learn from the last 2 years, both from me having been working in this area and the vaccine program. So it was required for the different parts of government to work together, the NHS to work with other parts of the community, particularly on the vaccine program, the voluntary sector, communities. And I wanted to focus on that word family, which doesn't appear very much in the white paper or that much in government policies in general. But the point I'm making is that for Pakistanis and Bangladeshis, I suspect the role of family and households and better social networks, religious services, etc., I think is having a significant impact. So for example, we have much lower rates of dementia, which was one of the lines on that table, than the white community. The integrated care systems which are coming in will hopefully have a benefit because it's bringing together these various groups, making better use of digital tools like the NHS app, particularly for prevention. And the final point is we do need more work on this. I mean, much of what I'm saying is not proven. So we need to do more research to understand if it is these differences that I've described that are leading to better outcomes. And there is a study starting soon called the Our Future Health Study, which will be able to answer some of those questions. Thank you.
Thank you very much. There's a lot to absorb there, but it was absolutely fascinating. And so basically the answer for levelling up health and longevity is for all of us to become Bangladeshis. But actually, I mean, this is really dramatic data. I mean, your first half and your second half were completely in conflict with each other. I mean, your first half followed a kind of Marmot story about social deprivation being the essential cause of these gaps, and the second half completely blew that out of the water. Yeah, I mean, this is not a paradox. I mean, this is a contradiction. I mean, you're essentially in the second half saying that, I don't know, larger families, more sense of community, less alcohol, lifestyle factors essentially determine much more than socioeconomic factors.
I'm saying the relationship between socioeconomic factors and those risk factors is different, certainly.
Well, lifestyle factors beat socioeconomic factors. I mean, otherwise, how is Tower Hamlets doing so well?
No, that's correct. So those socioeconomic factors, I hope it was clear, the socioeconomic factors obviously have to go through that pathway. They don't by themselves cause people to smoke or drink or have, but in the white community in particular, those patterns have been very strong, historically. We're not seeing the same pattern now, for example, in the Bangladeshi and Pakistani communities. But there are reasons that I mentioned for that.
But I mean, this is really quite dramatic, isn't it? I mean, it does raise a huge question mark over the conventional wisdom on health inequalities of the last 40 years or so, doesn't it?
It raises lots of questions. That's certainly true.
Well, talking of questions, we do have a few people with questions out there. I'm just wondering, I mean, as we have a small but select audience here, you should perhaps be given the first opportunity, but you can come back later. If no one's burning to ask something, we'll go to those of you online. So could we see if David Wood is there? David Wood, Chair of London Futurists. Are you there? And if you are, can you unmute yourself and ask a question?
Thanks. So this was a really fascinating set of information, particularly in the final sections, as was mentioned by you, David Goodhart. So my question is about progress that could be made to untangle the different effects of all these various influences. At the beginning, there were effects that were factors that were mentioned, education, employment, family circumstances. Can't we break this down in some way? And are there research overseas that could also shed light on this? You mentioned, Dr. Ali, some research in the US about the Hispanic Paradox. My feeling is there must be some useful data and analysis from other countries that could help us to work out which of the many socioeconomic factors deserve most of our attention, rather than us spreading our attention possibly too thinly without having desired effects.
So thank you, David. I mean, there is data, as you say, from other countries, the US, although each country's patterns of migration are different. The types of people that migrate is different. The social and education and the health systems are different. So I don't think it's that easy to read across. And I mean, some of the work I've done on cancer, for example, we've found what's happened in the UK is quite different to what happened in the US. So within one generation, for example, migrants that went to the US had similar rates of colorectal cancer, the Japanese that moved there. Whereas in the UK, that hasn't happened. They still have much lower rates of colorectal cancer. So I don't think we can directly read across, but I think we have enough data now from the UK, and we'll collect more data, and the 2021 census will be very helpful. And there's a lot of work going on which hasn't been published yet, which I think will help us to disentangle, what you described in the first part of your question, to understand how these social determinants of health are operating differently in different ethnic groups. And I'm hoping that will allow us to develop policies and ideas in terms of the learnings from that. But as I said, this is early stage work. I mean, what I've described today, as I said, you won't really find it in the public domain discussed in this way. But I was hoping this would encourage people in government and in academia to look into it further.
Can I just ask another question about why we think improvements in longevity have tailed off in this country? And it's not just this country, is it? I mean, this is a kind of rich country phenomenon. I mean, is it because the various sort of health bonuses, things that contributed to better health and greater longevity? I mean, the decline of dirty and dangerous jobs, all those miners who died of lung diseases, that doesn't happen any longer. Fewer people smoke, air quality is better, diet is a bit better. As they were, we've sort of got all the benefits of those things now, and that's kind of why we're reaching a plateau, is that?
Yeah, so that's one of the kind of major theories, and there is some truth in it, particularly for cardiovascular disease. On one of the slides I showed, there's dramatic reductions in cardiovascular disease mortality up until about 2010, and then it starts to plateau off. So there's a certain, and because that used to be by far the most common cause of death, then that would have a significant impact on life expectancy. There are other theories as well, as I said, in relation to post the kind of financial crisis, which had an impact on many countries in the world, particularly in the Western world, that led to cuts in public spending, etc., increasing deaths of despair, as they're described, whether due to drugs or alcohol. And we see an element of that in Scotland, actually. which has had particularly bad life expectancy outcomes. So I think there's multiple things. And the final point is kind of flu, actually. So we've seen that bad flu epidemics can have a significant impact on life expectancy from year to year. Obviously, we've seen it with COVID, but in the UK, there's some evidence for that as well.
And yet, I mean, given some of the data in the last third of your talk relating to basically healthier ethnic minority outcomes, I mean, given that the ethnic minority population is continuing to expand, relatively rapidly, it kind of that the plateauing off suggests that things are even worse for white British people, particularly in deprived areas. I mean, their longevity must be actually actively declining.
It's possible. I mean, although it's still a relatively, so the 20% of the UK population that is non-white British is much younger. You wouldn't see that full impact here. So in terms of the number of deaths, actually, it's a relatively small proportion of deaths are still in ethnic minorities. But you do see some of those patterns if you compare the Northeast, for example, which has a very small ethnic minority population, the trend in the Northeast versus London, which has the highest ethnic minority proportion. So we are starting to see some of those trends already.
Although the Northeast throws another spanner in the works, actually, doesn't it? Because well-being is actually much higher in the Northeast than it is in London. London has the worst well-being outcomes, doesn't it, of any region in the UK. Although, as you briefly had a suicide slide, and suicide is higher in the Northeast. I mean, suicide seems to correlate with deprivation. But well-being doesn't at all. I mean, the two parts of the UK with the highest levels of well-being are Northern Ireland, although there might be separate reasons there because the sort of communalism of Northern Ireland, and the Northeast. So you kind of there's almost a sort of it appears to be a sort of well-being factor for the good outcomes for South Asians, and yet it doesn't seem to be working for Geordies. It's a bit of a mystery as well. Anyway, lady at the front.
Is it time to drop?
Do you want to wait till there's a name and number, as it were?
Dr. Susan West, GP. Is it time to drop our vision of the nuclear family?
That's a more sociological question than for a doctor. I mean, of course, issues around family, I can see why governments have, of both colours, been reluctant to kind of tackle it for a long time, and not to kind of prescribe or suggest how people should, the best ideal family structure. But there is some evidence from what I've showed that these extended family structures do produce better outcomes for, as I said, things like dementia, living alone. Elderly people living alone tend to have worse outcomes than those that don't live alone. Living in care homes, for example, again, we saw it in COVID, but it predates COVID as well, tend to have not as good outcomes as those that live with their families. So you've asked an important question which a politician would have to give a better answer to.
That was really interesting. Robert Eade from Policy Exchange. You talked a little bit about solutions at the end, and I think everyone here is quite struck by the 20% of total factors of health come due to healthcare, and 40% are social determinants and 30% are behavioural factors. Obviously, prevention initiatives often take quite a few years to filter through. What one intervention now would deliver best bang for Conservative buck?
If I knew the answer to that question, I'd be Health Secretary. That's right. I'm afraid I can't answer that question directly, but that work needs to be done. I mean, prevention, the Secretary of State mentioned last week that there's going to be a kind of baselining assessment of how much money is being spent on prevention and what outcomes are being achieved through that. I think what we do know is that a very small proportion of the NHS budget is spent on prevention, and I think what we also know is that not enough work has been done maybe to evaluate the impact of those interventions. I mean, for some things, for example, raising taxes on tobacco, that's obviously had a major impact on smoking rights, and that's led to some improvements in life expectancy. We're seeing similar things like with the sugar taxes now that's in its early days. But if you're asking for the first question I'd be interested in looking at would be really interventions in childhood, early childhood. And although we won't know the answers for a longer period of time, given the trajectories that we see, and even for ethnic minorities, as I said, it's that difference you start to see earlier. So deprived white communities don't do very well at school. Deprived South Asian and black African communities do quite well at school. So it seems that there are, again, going back to the family, things that we need to work on as early as possible. So I don't know if it's the best use in terms of cost effectiveness, but I think we need to establish that urgently, although it will take a long time to get a definitive answer.
Just a sec. What was that? What were those proportions again?
Well, Raghib will know because he did the
Right.
20% was basically health care,
Right.
including so
Right.
the NHS's kind of usual
Yeah.
functions, primary, secondary care, etc. And broadly speaking, 80% is other things, but that was broken down roughly. And these proportions are not exact, but the biggest proportion was social determinants, then risk factors, and I can't remember actually what the last 10% was. But
I mean, are these proportions not up for review, given what you were saying in the last section of your talk?
Yes, no, I mean, he's looking at it again. Yeah. I mean, I still think the 20% is probably quite accurate, but
Right,
the relative
right.
balance of
Yeah.
the others may be different.
Right. Gentleman over there, sorry, I'll come to you after.
Hi, I'm Nick Katuna from the Health Service Journal. You talked about integrated care systems and integrated care boards as they're emerging to have a potential benefit to this. In what way can they kind of have this positive impact, and where do you see their sort of standing further down the line in 5-10 years, if they still do exist in that time? Because some of these policies can see them kind of go away as like CCGs and all before them.
So no, you're right, reorganizations happen frequently in the NHS. I think my hope is, and this is partly based on what the Secretary of State was saying last week, is that if the focus is now on prevention within the NHS as well. So the NHS is not the primary place where prevention will occur, but it has an important role. And it's a trusted institution, and it has many people within it who could help to answer these questions, working with other parts of government. On the specifics of the integrated care systems, from my understanding, is that they will have kind of reducing health inequalities as one of their key objectives, and they will have obviously directors of public health and other people from that background whose focus is more on prevention, whether mainly from the local authorities and other local organizations. But I think it's more a change in emphasis as opposed to just thinking maybe in the past more about the primary and secondary and tertiary care. But we'll see.
Okay. Now suddenly, as we come to past 7:15, everyone wants to ask a question. Okay, well, but a couple of last questions. Gentleman at the front and lady at the back.
David Winder from the Silver Kettle Foundation. The question here was why London was most improved. I think in my study it was the impact of the increase in the quality of teaching. A lot of money was spent on improving things about 20 years ago. Would you like to comment?
So there is, I mean, it's not my area to comment kind of definitively on this, but I think even outside of London, we see that ethnic minorities tend to do better. Those on free school meals tend to do better than the whites that are not on free school meals. So it's not just a London effect, but of course the improvement in London is more complicated than just because of ethnic minorities. It's also changes in, as you said, in the teaching and academies, etc. Various changes that have come about. But that pattern that was described is national. It's not just a London effect.
When it almost is sort of this sort of combination of sort of ethnic aspiration and ethnic traditionalism, almost the sort of things that are seen as often sort of in conflict are actually sort of combine rather well when it comes to health and longevity.
I mean, I think just to final part on that, there's no doubt, at least in my own personal experience, and most people I speak to, that as an immigrant, from an immigrant, particularly from a poor immigrant family, your only route to kind of escaping that is education, in general. Yeah. Is education. So that was certainly my experience and many other people that I know. And that the driver may not be so strong in other communities.
Final question.
Woods from Collider Health and connected to the All-Party Parliamentary Group for Longevity and Business for Health. But so there's been a lot of chats with some of the ICSs and leaders of the ICSs starting to ask the questions, if all the reasons and the solutions for addressing health inequalities actually lie outside health and care, why is the NHS and care people in charge of health inequalities? Which other government departments really should be looking at this?
So
Would you say, is it education, communities?
No,
to
it's
really look at health inequalities, it's actually
Explain what ITS is.
ICS, Integrated Care Systems, or
ICS,
Integrated Care Boards.
Yeah.
I mean, the point is absolutely valid that the majority, if you really want to improve these outcomes, you can't rely on the Department of Health and Social Care or Integrated Care Systems or the NHS alone, but they do have a role. I mean, the good thing, I hope, with this new Department of Levelling Up is that that's meant to look at, that kind of that cross-government approach, but of course the Department of Education is important. Treasury, of course, has a role, work and pensions. This kind of cross-government, whole-government strategy for levelling up is probably the only way. And maybe it's one of the reasons why we haven't made some of the improvements over the last 20 years, because there hasn't been that in the past. But it's something certainly going forward, I think it seems that both the NHS and government recognise.
So really, other government departments really have to see it as their role to actually reduce health inequalities.
They do. So this is something I don't remember exactly where I read it, whether it's in the white paper or somewhere else, but each part of government in terms of their policies should be thinking about the impact on healthcare inequalities, or health inequalities, sorry. Yeah.
Great. Well, I think we're going to have to wind it up there. My head is still spinning with all that fascinating information. Thank you very much, Raghib.
Thank you.
Just to say, the series continues. We have Amanda Spielman's going to be talking about schools and levelling up in a few weeks' time, I hope. And Jamie Driscoll, the Mayor of North Tyne, is talking about the politics of levelling up also, well, in a couple of months. And we have various others planned beyond that. So levelling up continues. Thank you very much, everybody out there, and thanks everybody. As I say, the select group here. We have some drinks at the back if anyone wants to stay, and I'm sure Dr. Ali would be prepared to answer a few more questions.
Sure.
Thank you very much.
Thanks, Dave.